All right, fantastic. Thank you guys so much for having me. My name is John Huang. I'm one of the new interventional radiologists here at UAB. A little bit of background about myself is that I did a lot of training everywhere else in the country except for the South. So when I came back here, it was really cool because I could bring a lot of things I learned back here. And the patient population here is wonderful. I mean, a lot of people are very appreciative, and pain is one of those really tough things to handle, both from the medicine side and from the proceduralist side. And I just feel like it's something that we can talk about and maybe work together to improve the lives of our patients with. So without further ado, let me jump into some cases to kind of demonstrate the breadth of interventional pain that we can perform, and then kind of, I guess, touch on topics that are more germane to your practice as well. So the first patient I want to discuss is a 58-year-old female with pain in the upper back. If you turn your attention to the MRI, you can see that you have vertebral bodies that look pretty normal, and then you have a vertebral body that looks squished. So when you have this, essentially it's an acute vertebral body or vertebral compression fracture. And for this patient, this was incredibly painful. I believe she presented to the ED, was given pain medicine and non-operative therapy, eventually couldn't take it anymore. And Dr. Neely reached out to me and asked me if I could do anything. And I took a look at the MRI, I talked with the patient, and we ended up scheduling her for vertebral augmentation. And when I say vertebral augmentation, it basically embodies all of the spinous procedures that you think about, like kyphoplasty, vertebroplasty, and what it involves is putting in these trocars percutaneously into the vertebral body, and then either ballooning them up to re-expand a little bit of height or not, and then placing cement in order to reinforce that bone. Because typically the reason why people get these fractures is because they're osteoporotic. Occasionally they can happen because patients have traumas, so they have axial loading trauma, or if they have metastatic disease. Regardless of whatever etiology it is, it hurts a lot, and patients get relief from these procedures. This is just another example. This vertebral body doesn't look as bad as the other patients, but this is another example of how we can put cement in and essentially solidify the collapsed vertebra. Now, unfortunately, some patients don't make it to me in time. So this is a patient who had her MRI performed in March, and you can see the wedge-shaped defect here. And this is a different patient, but I scheduled her as soon as I could, but it was already 4 or 5 months later. And by the time she got on my table, you can see that it looks different. It looks worse. And I actually drew these and then put them to scale side by side. The green is what it looked like back in March, and the red is what it looked like in August. So you can tell there's, in addition to the 50% fracture she basically fractured an additional 25% on top of that. So these do get worse. She had progressive pain, and we were able to fix this, but this is kind of the natural progression of what happens when you leave these be. Now, here's just some numbers that our good friends from Merit provided to me. So 700,000 fractures of the spine occur every year. About 150,000 patients are hospitalized for pain related to spinal fractures. And the average length of stay for these patients is 8 days. Now, that's really important, and you'll see why, because there are actually 2 studies that I want to tell you guys about that are very meaningful for our practice. And this is just a slide about how to identify vertebral fracture. You don't really need me to go over this part. What I do want to touch base on is imaging requirements. If you ever suspect a vertebral body fracture, please just move on to a CT. You can get a radiograph, but they aren't as helpful as you think. The CT scan is great. MRI is even better, but sometimes MRIs can take a while, and there are a lot of contraindications for MRs for patients. And if there ever is a contraindication that can't be circumvented, then a bone scan is good enough. The reason why MRI is really good is because it tells you the acuity of the fracture and whether or not it will be amenable for height restoration and vertebral augmentation. Going back to the statement length of stay. So if the average length of stay is about 8 days for patients with VCF or vertebral compression fractures, vertebral augmentation can reduce the length of stay by about 4 to 6 days. And that's really important, especially right now during COVID, because if we can get these patients out in half the time, that's going to be really important to keeping our COVID numbers low and also just keeping people out of the hospital. So I think, inpatient vertebroplasty and kyphoplasty, unfortunately, isn't something that is performed routinely by our division, because I'm one of the few people that performs this procedure, and I rarely see inpatients. I've seen a couple, but not nearly the number that I would expect in this population. I think part of it is because people are essentially treating them non-operatively, which there is data to suggest that can work. However, there's a lot more data to suggest that vertebral augmentation is the way to go. And my personal belief is that vertebral augmentation is the way to go. So I talked to Dr. Neely beforehand, and she said one of the most important things for you guys would be who to contact and what to do for a procedure before the procedure is actually scheduled. So I put together these pre-procedural checklists to hopefully help you guys. So basically, if we're going to do vertebral augmentation, I do want INR platelets. They should be MPO'd the night before, and they can be performed as either inpatient or outpatient. And also, I do this myself. One of my partners, Dr. Saleh and Dr. Al-Qadari, also do this procedure, but also our friends in neurosurgery, Dr. Jesse Jones, also performs this. So if for some reason somebody's not available, or it's just easier to get hold of somebody else, these are kind of the options that I would pursue. So that's kind of it for VCF for now. Is there anybody with a comment that they would like to make, or any questions?
Just a curiosity around the inpatient doing of it. Is that something we've ever run into insurance prior authorization or other concerns that would force it to be an outpatient procedure?
That's a great question. I don't really know. And that's because I don't really handle the money aspect of it. But from my experience in dealing with the one patient that we've had as inpatient, that went off without a hitch. She was able to get treated during the stay, and I haven't gotten any pushback for it.
Oh, great.
So my personal belief is that if you think a patient is going to be benefited by the procedure, we do the right thing for the patient. We try to do it and get them out. And if they give us blowback, we'll handle it at the back end.
All right.
Taylor, do you know anything about this? Taylor Cameron's my spine rep from Merit, and he actually helped set up this talk for us. So I'm very appreciative. But do you have any insight into that question?
Yeah, no prior authorization is needed for Medicare and Medicaid. It's covered for both of those. There is sometimes pre-authorization needed for private payers.
Okay, so there you have it. Thank you very much, Taylor. All right, so next case. So now we're going to move on to other things, because VCF is one of those things where we can treat, and people know we treat them. These are other things that you might not think about, but definitely benefit your patients. And they may not be done while the patient's in the hospital, but pain is one of those things that kind of never goes away. And managing pain is sometimes a very tedious process. So I hope that after this presentation, you'll understand how many different things we can do, what types of pain we can treat, and most importantly, how to get a hold of us. And that, I think, is the most important thing. So that way we can really build a pipeline for these patients. So without further ado, I'm going to go down probably 8 more cases just to kind of demonstrate the various techniques we can use and the various patients we treat. So this patient is a patient with low back pain, very nondescript. And what you're seeing right here is a needle in the epidural space. So this is what people call an ESI, or epidural spinal injection. A lot of people do these. Anesthesia does these. IR does these. I think a lot of neuroradiologists do these. Basically, it's for chronic neck and back pain. The efficacy is incredibly variable. I usually put patients between 2 weeks to 3 weeks of improvement in about half the patients. And the other half usually either don't get any improvement at all, or a very, very, very tiny percent of them actually get worse because they get a reaction to the injection. So these can help, and they're worth trying if PT has already failed. Complications are very minimal. However, they can be serious. You can get spinal artery embolization, epidural hematomas, or intrathecal injections by accident. Contraindications to this procedure are going to be high NR and active infection. So for the pre-procedural checklist for ESIs, I don't need a platelet or an INR beforehand. They do need to be MPO, because at UAB, we do these cases under moderate sedation. They don't need to be done as an inpatient. We can do them, but there really is no need. And we can be more than happy to set them up as an outpatient. And to my knowledge, here IR does them. A lot of other people do them, but I just don't really know who they are. But we do them for sure. Case number 3. So this is along the similar line. if we're talking about ESIs treating lower back pain that is chronic, it's usually for more nebulous pain that is localized. In this case, where patients have radiculopathy that you can localize to a nerve root, I do something called a nerve root injection or a transforaminal epidural injection. And this is really good for radiculopathy, so pain that goes down the leg. So if you have a patient who's complaining about pain and it starts off in the back and goes down the leg, this might be a good option for them. And once again, the complications and contraindications are very similar to the ESI. It's essentially the same procedure at a different location. And then with the same pre-procedural checklist. Other injections I do, so facet joints. So a lot of times patients will have facet arthropathy, and you may have heard of the term rhizotomy. That's a RFA of the facet. I don't do rhizotomies. I do facet joint injections because, I don't know, I've just never had a rhizotomy as part of my practice. I'm sure I could perform it if requested, but I typically just inject them with a combination of local anesthetics and steroids. And everybody, please feel free to interrupt me at any point in time if you have a question or comment. I'm very open to just discussing any part of this, or whether it be about the technique or the setting up of the patient. Other things we do, SI joint injections. So usually this is for patients with pelvic pain and SI joint arthropathy, and usually you'll see this on CTs, and patients will typically have a hooked osteophyte. These can be a little bit tricky under flora. They're doable, but they can be a little tricky. This is a procedure that I've done a few times and already once at UAB. So this is for coccynodynia. So basically, if people have butt pain, very common in people who bike a lot or have broken their tailbone, they'll have this. And if it's a problem, I can do something called a ganglion impar block, where I put a needle directly through the coccyx and essentially lyse the ganglion impar, and it works very well. With all of these, patients don't need to have INR platelets. They do need to be MPO. They can be done as inpatients or outpatients, preferably as outpatients. And I know I do these. Other people may as well, but I know for sure that we can take care of these kind of patients for you. Now moving on to potentially some cases that are more niche. So this is a patient with chronic pancreatitis. I'm not sure how often, do you guys often deal with patients with chronic pancreatitis, or do they get shifted off to surgery?
They're generally a medicine admission unless they are acutely decompensating and needing active surgery.
Okay. So for patients with chronic pancreatitis, less so with acute pancreatitis, but with chronic pancreatitis, they can get severe abdominal pain. And one of the things that I perform for that is something called a celiac plexus neurolysis, where I go under CT and I will put a needle essentially through the back into the celiac plexus and inject a combination of lidocaine and ethanol and ablate that. It works wonders for pain related to cancer, in addition to pancreatitis. And there's growing literature that shows that this may also help patients with median arcuate ligament syndrome. So if you have any of these kind of patients and you can't really deal with their pain effectively, or you think you're just dumping opioids, let me know and I'll evaluate them and see if they're a candidate for this. There's two ways to do it. You can do the anticrural lysis, or you can do a retrocrural. The retrocrural essentially hits the splenic nerves as they cross the vertebral body. Both are very effective. There is a slight risk of nerve injury using the retrocrural approach, so I typically prefer the anticrural approach if possible. Sometimes you just can't get there. And it's great for abdominal pain, malignant versus non-malignant, complications, diarrhea. So I put paralysis on there because when I did my fellowship at Mass General, they told me of 2 patients who actually became paralyzed after a retrocrural block because the ethanol was injected into a spinal artery by accident. So that's another reason why I typically prefer anticrural block. And once again, that is 1 in a million. These are typically very safe procedures. Okay. So pre-procedural checklist, IR platelets, yes. MPO before, yes. Either inpatient or outpatient. I know I do these. I've heard that GI does these as well. So if for some reason, you can't get a hold of us or it's not working out, then GI is another option. So this is a MRI of a fibroid, and typically with patients with fibroids, they get pelvic pain. Now, we do fibroid embolizations in order to relieve bulk symptoms as well as pain as well as bleeding. However, one of the complications of this is that you get pelvic pain related to fibroid necrosis. And in order to fix that, I do something called a superior hypogastric nerve block. So there is a plexus that lives essentially beneath the crotch of the aorta, and it supplies the pelvic viscera, and basically all the pain fibers from the pelvic viscera travel in that direction. So I can actually block that and provide relief for pelvic pain. So if you have a patient with pelvic pain, this is definitely an option. Now, that being said, it's not just for fibroids. People do this for cancer. I did one probably about 2 weeks ago on an inpatient for cancer. It didn't really help her that much, but her symptoms were more anorectal. And I think that she might have benefited more from a ganglion impar. Regardless, this is really good for pelvico-abdominal pain. So celiac plexus is really good for abdominal pain. This is really good for pelvic pain. And once again, INR platelets before, MPO before, and I'll do this as inpatient or outpatient. And now we're moving on to the super niche cases. These are kind of things I brought to UAB. And this is a MRI of a patient. Now, this is one of those things that's really interesting. 99% of older people will have this problem. And if you look at right here, so you see a disc right here and you see a disc right here. But what you notice is there's no disc right here. And these vertebral bodies look kind of crunched on each other. This is essentially degenerative disease of the disc, which happens with age. I can treat the pain related to this now. And the procedure is called a basivertebral nerve ablation, where essentially what you do is you put in two trocars into the bone, and you basically ablate nerves that live right here and right here. And they're highly efficacious. They're really good for people with modic 1 and modic 2, which means they're still having pain. And we're doing them here in conjunction with neurosurgery. So far, it's been a very, very successful endeavor. We're treating probably about 2 to 3 patients every month, and the results are outstanding. And this is something that really you couldn't really do anything about before. Discogenic pain now has a cure. So if you have patients with discogenic pain or vertebrogenic pain, let me know, and we'll evaluate them for basivertebral nerve ablation. Once again, these are from as outpatients, and they do need INR plates in to be MPO before. Now, it doesn't take a radiologist to figure out that this spine looks really weird. So you can see right here that these are step-offs. So these are fractured, fractured, fractured. And you also may notice that, look at this vertebral body versus this vertebral body. There is fuzziness in this that isn't present here, and that's because these are metastatic. So these are due to metastatic disease, and basically the tumor has caused the vertebral bodies to collapse. What we can do for this is we essentially ablate these tumors inside the bone, and then we fill the void with cement. What this will do is it will both kill the tumor and it will stabilize the spine. So this is another one of the super niche procedures that we perform here. And some people perform these without the cement. I always cement, because I think if you don't, you're just asking for that vertebral body to fracture. That being said, I've left off one group here who also should be contacted for these kind of patients. Radiation oncologists can use SBRT and treat those as well. The benefit of having cement or having IR or neurosurgery do this is that we can cement. Once you ablate the tumor, there's no bone left. So that is highly likely to fracture. So I've gotten a few referrals from our radiation oncology colleagues as well to cement these afterwards. I think that works beautifully as well. So if you think radiation oncology is better for this patient and you want to send to them, fantastic. So that's one group I forgot, but definitely reach out to them as well. Now, this is something interesting. This is a patient with chest wall pain and dyspnea. And you might not have heard of this before, but it's called intercostal crineurolysis. This is for patients who have chronic chest wall pain. So if you have a patient who had trauma, surgery, or fibrosis, and they're having pain in their chest, and it's in a radiating distribution from the side to the front, let me know, and I'll do a block and then potentially a cryoneurolysis. This is one of the best new procedures that we've created in the past 10 years. And it's been highly efficacious. I've had a patient at Children's who I treated one side. I got a call from her dad 2 weeks later begging me to treat her other side. While I was working her up for the other side, they asked me to retreat additional levels on the first side I treated. And I asked them why, and they told me the reason why is because before my procedure, she was unable to sleep at night. And after my procedure, she was able to sleep. And when I asked her directly, how much your pain has improved, she told me 80% at least. So this is a procedure that I think can bring a lot of relief for patients who are suffering from either metastatic disease or chronic pleural disease, trauma, or prior surgery. So this will be predominantly done as an outpatient. I'll do the block as an inpatient though. And it's a two-step process. We'll take care of it as soon as you contact me. We'll evaluate the patient and we'll decide, how we're going to treat them or if they need this. And this is kind of a interesting consult I received a couple of weeks ago. It was a 62-year-old gentleman with persistent hiccups. These hiccups were so bad that they couldn't do anything about it. I actually got a call, I believe, from one of the hospital attendings asking if I could perform a procedure called a phrenic nerve block. And I did this with bupivacaine, and I called the patient a couple of days later and they said the hiccups are gone. They ended up returning about 5 days later, but from all the data that's out there, and bear in mind, the data that is out there is essentially all case reports. This is it's very promising for, intractable hiccups. And I think that if you do have patients with this problem, it's worth sending them to me for an evaluation and possible block, and just to kind of see if it works, because it makes sense, it's basically hitting a reset on the phrenic nerve. And by using temporary agents, you aren't going to be risking any sort of long-term paralysis. Okay. And once again, no INR platelets required, does not need to be MPO, can be done as inpatient or outpatient. And I think only I'm crazy enough to do this for now. Other things we can do. So shoulder pain. Patients with frozen shoulder or post-op shoulder rigidity can benefit from something called shoulder embolization. We will go through the arteries and essentially embolize vessels going to the capsule. And this is proven to be incredibly effective for adhesive capsulitis as well as post-operative stiff shoulder. They're pretty much only doing this in Japan right now, but the technique is well described and I'd be happy to start doing them here. Genicular artery embolization for osteoarthritis and knee pain. I've actually already talked to our orthopedics colleagues and they are completely on board. If you have patients who are non-operable candidates with knee pain, consider sending them to me for evaluation for GAE. Migraines. So some patients who have fractured migraines can benefit from something called spinopalatine block. It's incredibly easy. We just basically tilt the patient's head back, put a catheter in the nose, and drip a local anesthetic. Finally, there's actually a trial going on here as well run by Dr. Gunn on bariatric embolization. If you have, anybody who not a great surgical candidate is obese and is interested in trying this, we go in and we essentially embolize arteries feeding the fundus of the stomach, and that's supposed to decrease levels of ghrelin, and that will curb appetite. The BEAT obesity trial has demonstrated that patients do better from a weight perspective as well as A1C, and it's definitely something that would be of interest for a lot of people in Alabama. Finally, this is probably one of the more important pages. This is how to contact me. So if you have inpatient consults, go to UAB paging and you go to IR on call. That will get you our fellow or resident. If you have any outpatient consults, it's 205-801-GO-IR, and that'll take you to Lee Lyle. If you ever have any trouble reaching anybody for anything, text me. And I'm serious about this. That's my phone number. Just text me and I'll look into it. Okay. I might not do the procedure, but at least I'll look into it and tell you, what I think is going on and how to proceed. Dr. Jesse Jones is my partner in neurosurgery, and he does a lot of these pain procedures with me. And we're really trying to build interventional pain here and provide, an option to opioids for our patients. And I think I think there's a lot of room to grow here, and I'm looking forward to working together with all of you guys. And thank you so much for having me here and giving me the opportunity to chat with you. On a side note, Dr. Neely mentioned to me that sometimes it's difficult to figure out what to do pre-procedurally. There is an app that I helped co-develop. It's called the SR Guidelines app. It's available in the Apple Store for free. You can download it onto your iPhone. There will be an Android version coming out at some point in the near future. But if you download it, you can use it. And essentially any procedure that we do will be listed on this. It'll tell you what antibiotics and what the pre-procedural guidelines are for not only laboratory values, but also how to hold anticoagulants. So I think that this is definitely something that you should have if you're interested in figuring out what to do for patients before procedure. Thank you so much for your attention. Do you have any questions or comments?
For the referrals, do you know if there's a message center option or anything? I'm particularly thinking about the potential for overnight wanting to be able to send a message center to get someone referred for outpatient who had presented to the ED as a connection to care.
I think if we're gonna talk about if you want to send a patient for outpatient, the best person to send a message to is Lee Lyle. So that would be any outpatient query would be Lee Lyle. If you want us to do something as inpatient, then UAB paging IR on call, be the best person. But for that exact purpose that you just described, I would send a impact message to Lee Lyle. She's usually very good, and CC me on it. If you just CC me on everything, I typically check it every day. So it should expect a response, or somebody to respond within 24 hours. Any other questions or queries, like anything that I didn't touch on that you guys want to know about? Like what kind of things do you guys find yourself struggling with in terms of pain?
Back pain is huge. You've hit on that pretty good. I think that's kind of one of the good things I heard about from you. So
awesome. Yeah, like back pain's a huge problem, and unfortunately, there are varying opinions on how to triage back pain. Yeah, I understand that a common practice is bracing, discharging with pain meds, and unfortunately, what happens is you're correct that the pain does stop eventually once the vertebral body collapses to nothing. And you know, unfortunately, there are papers out there that are seemingly well constructed that are against vertebroplasty, and that being the Vertos trial. But if you actually dissect it out, you'll realize that their methodology was flawed in how they actually go about trying to figure out pain scores. You know, so I would say that in my experience and in the experience of my colleagues who perform these, patients do really well. When I used to talk to congressmen regarding why interventional radiology should be supported, I would bring up vertebroplasty and kyphoplasty, because these are the cases where patients come in unable to walk, unable to stand, and when you're done with your procedure, they walk off your table. Okay, so I'm a big believer in these procedures.
yeah, it's just nice for us to have something else in our arsenal for that besides pain meds and surgery. So
definitely. And that being said, I mean, Jesse Jones is a neurosurgery faculty, so you know, it's not like we're competing. We're cooperating together to make this happen.
100%, yeah.
All right. Well, I got nothing else, guys.
I guess I'll add a clarifying question, like in terms of what's the point to sort of trigger that back pain consult? Like, is there if someone goes 2 days with no improvement, that's where you feel like for sure IR needs to, or they need to be evaluated?
So here's what I would say. Any patient who's older than 50 years old, postmenopausal with sudden back pain, sudden onset back pain. Also, when you feel their spine and you do your stepwise mashing, and all of a sudden they're like, ow, or they try to squirm away from you, that would definitely be an indication to get some imaging. And also, if they tell you, I'm having trouble standing or walking, these are the reasons why you would trigger a CT scan. Okay.
And then if that CT scan shows a compression fracture,
Let me know. Because if it's old, we'll figure it out. If it's new, we'll figure it out. And once you let me know, I'm going to get on it, and I'll kind of take over that aspect of it, if that's what you guys want. Okay, great question.
Thank you. I'm going to stop recording.
Alrighty.